and welcome to our channel MedStudy. Today in this video we are going to see about clinical examination of abdomen in surgery. So let's get started. First, coming to inspection. Here we have to look for shape and contour of abdomen, whether it is normal, scaphoid or distended. We have to look for umbilicus, its position, whether it is inverted, flat or everted. We have to look for skin over abdomen for scars, pigmentation, striae, engorged veins, etc. We have to look for movements of abdomen during respiration, any visible peristalsis or pulsatile movements if present. Now we have to look for visible swelling. We have to look for site and extent of the swelling, size, shape and surface of the swelling, margin of the swelling, whether it is moving with respiration or not. We have to do rising test, whether the swelling is parietal or intra-abdominal. We have to look for the hernial sites, whether there is any swelling, any expansile impulse on cuff, and we have to look for external genitalia. Now coming to palpation. First is the superficial palpation. We have to look for temperature and tenderness. We have to feel the abdomen, whether it is soft and elastic. We have to palpate for muscle guard. We have to palpate for any rigidness if present. Now coming to deep palpation. Deep tender spots. First is gastric point. It is a point in mid-epigastrium. Duodenal point. It is a point in transpyloric plane 2.5 cm to the right of umbilicus. McBurney's point. In the right spino-umbilical line at the junction between medial 2/3 and lateral 1/3. Amoebic point is in the left spino-umbilical line at corresponding McBurney's point. Renal point is a point at the junction of lateral border of erector spinae at 12th rib. Murphy's sign. It is positive in patients with acute cholecystitis. At the height of inspiration, inflamed gallbladder impinges on the thumb, and when the patient catches the breath and the patient wins with pain. Deep palpation. Continuing with deep palpation, palpation of lump if any, position and extent in relation to the abdominal quadrants, shape, size, surface and margin of the lump, consistency, mobility with respiration, mobility from side to side and up and down, fixity to the skin and underlying tissue, knee-elbow position to decide whether it is intraperitoneal or retroperitoneal. We have to do palpation of organs, we have to palpate hernial sites, and we have to palpate external genitalia for any abnormality. Now coming to percussion. We have to do shifting dullness, we have to do fluid theory, upper border of liver dullness, upper border of splenic dullness, and percussion over the abdominal lump. Last point is auscultation. You have to auscultate for peristaltic sounds. Normal, whether they are increased as an obstruction or whether they are decreased as in peritonitis. We have to auscultate for bruit and we have to auscultate for venous hum. Now these are some must examine points in abdomen, which include supraclavicular lymph nodes, hernial orifices, femoral pulses, genitalia, bowel sounds, anal canal and rectum. So this concludes with abdominal examination in surgery. I hope you liked the video. Please do like, share and subscribe to our channel, and don't forget to press the bell icon so that you will never miss an update. Thank you.